We are truly honored to have you, Dr. Tahmeed Ahmed, as our plenary speaker of the ISBM International E-Conference 2025. Dear audience, let's join me in welcoming Dr. Tahmeed Ahmed.
Thank you very much, Dr. Salim. That was a very generous introduction. First of all, I would like to thank ISBM, in particular, Professor Patwari, Dr. Rahman, for the very kind invitation. It is really a privilege for me to be able to speak to all of you today. If you can please allow me, let me share some slides. So today, over the next 25 minutes, I'm going to talk about icddr and how it has been improving the lives and health of people through research. I thought that this would be pertinent because many of you who are present in today's audience, you are actually part of icddr. As the executive director, I'm simply trying to build upon the work that you have had done in the past. And in the audience, I must acknowledge the contribution of Professor Rita Caldwell, Professor KMS Aziz, and of course, our very dear friend, Professor Anwar Haq. There are many others in the audience, I'm sure. I don't see them, but they have contributed to icddr. And I thought that I should also talk about where icddr stands today. And this would be very important to our, young colleagues. Let me start with this thing, which is, of primary interest to many of us here. This is what we saw in the hospital, the cholera hospital in Dhaka, the largest diarrhea hospital in the world. 11:37 a.m., you can see this gentleman. He's almost collapsed. And this is 2 minutes later. There's a team of workers who are trying to resuscitate him. And then this is at 12:54 p.m., okay? And then this is in the late afternoon when he is ready to leave the hospital. So this is a case of cholera with severe dehydration. And this remarkable recovery has been possible because of these two research developments that took place in Dhaka many, many years ago. First of all, on the left-hand side of this slide, you can see a saline bag, which is known as cholera saline or Dhaka solution. Even in very classical textbooks of microbiology, you may find this name. This was developed in 1964, and today we are still using this all over the world to take care of severe dehydration due to diarrhea. And the other, of course, ORS. And the first trial was done in Dhaka, and that was in 1968. And today you can see ORS on the time cover. This has saved about 70 million lives so far. I can't recall any other intervention that has had such a profound impact on human life. I want to turn the chapter to something else that would be of interest to you, microbiologists. And the focus now of icddr is how we can transform evidence into policy. I'm going to give some examples. And this is cervical cancer. Today as I speak to you, we have about 8,000 new cases of cervical cancer every year, and about 5,000 die each year, 5,000 women. These are the formal, official figures. You can imagine what the unofficial figures can be. On the left-hand side, you can see a cartoon of the cervix. On the right side, you can see the erosion, which, heralds cervical cancer. And we now know that 90% of cervical cancer is caused by a virus, the human papilloma virus. And there's a vaccine that can prevent human papilloma virus infection and hence cervical cancer. The problem with this vaccine, the currently available vaccine, is that it is very expensive. You require 3 doses, and many a time there are stockouts all over the world, particularly in low and middle income countries. So that prompted our scientists, our vaccine scientists, to take up another vaccine, Secolin, that was also meant to take care of human papilloma virus. They compared it with Gardasil and found that this new vaccine is as good as the conventional vaccine. No sooner had the results been disseminated, the World Health Organization recommended the single dose new vaccine as the vaccine against human papilloma virus for the entire world. So you can see a very classical example of research being translated into global action. So let me again go back to the history of icddrp. Many of you are aware that it was established in 1960 as the Cholera Research Laboratory, but now we do research on anything that is of importance to the life and health of people living in low and middle income countries. And you can see this ranges from different infectious diseases, maternal and child health systems, even social issues like domestic violence. We are governed by the ICDDRB Act, and we have an international board of trustees. Right at this moment, we have about 4,200 staff, and we have more than 400 scientists. And I must say that we are so proud that many of our scientists happen to be microbiologists. Most of them have taken their foundational education and training in the Department of Biochemistry and Microbiology, University of Dhaka. ICDDRB is multinational, multidisciplinary. We just have 2 core donors, the governments of Canada and Bangladesh, and we are so very much grateful to them. Most of the research grant comes through the efforts of our scientists who apply and compete with many others and bring in the funds. In fact, 87% of the total budget of ICDDRB is restricted, brought by scientists, and that also includes me. As I said, that anything that is of importance to low and middle income countries is our mandate. And this includes food insecurity, malnutrition, communicable as well as non-communicable diseases, antimicrobial resistance, and now humanitarian issues. And I'm going to tell what we are doing for the Rohingya population. We worked through a strategic plan. This is a 5-year strategic plan. And let me now tell you about a couple of other innovations. Visceral leishmaniasis, in other words, Kala Azar, that is a deadly disease. And you can see on this slide a patient who has recovered from visceral infection, but he has all these cutaneous manifestations. So this is cutaneous leishmaniasis. We have a core group working on visceral leishmaniasis. They worked on new treatment. The conventional treatment was very cumbersome, very painful, but they have worked on newer treatment. They have worked on vector control. They have worked with the government of Bangladesh. So much so that Bangladesh in the world is the only country, is the first country that has been able to eliminate visceral leishmaniasis. This, again, is an example of how our research has led into policy translation. Dr. Salim talked about the microbiota-directed food for malnutrition. This is what we have been doing for the last 10 years, a huge portfolio of clinical, preclinical, translational work with Professor Jeffrey Gordon has led us to the development of microbiota-directed food. This, I think, is one of the first interventions that has come out from our very deep knowledge of the human gut microbiota. And this is made of, soybean flour, chickpea flour, peanut paste, And then you can see the green bananas, the pulp of the green bananas. And of course, we have oil and micronutrients. And this microbiota-directed food works as a food not just for the child with malnutrition, but also for resuscitating the good bugs in the intestines so that they proliferate and do all the good things that we have shown through our results. This is a child that we are talking about. On the left-hand side, you can see a child with severe acute malnutrition, just inches away from death. And you can see just within 1 month, the child is thriving, ready to leave for home. And the summary of the findings, which were published in 2021 in the New England Journal of Medicine, tells us that, yes, this is a very promising intervention that has been derived from the knowledge of the gut microbiota. Based on that, The Economist last year published a 2-page article, and the article concludes by saying that for many children all over the world, perhaps this intervention could be an answer. Right at this moment, this new intervention, as well as some others, are being trialed in Bangladesh, in India, Pakistan, and several countries in sub-Saharan Africa. Let me talk about tuberculosis, that almost is a national disease in Bangladesh. There is a huge amount of work going on with the National TB Control Program. I want to highlight just one issue, which is a portable X-ray based on artificial intelligence. On this slide, you can see a health worker, a female health worker taking a boat ride, and she has a backpack. What she does, she goes to a village, assembles people, asks several questions, and then she installs her chest X-ray, takes the chest X-ray. Within moments, she tells the individuals that, look, you have a 70% possibility of having lung tuberculosis, or you have a 20%. You should go to the nearest Upazila or sub-district health complex. What ICDDRB has done is that it has empowered the government's National TB Control Program to have this operational in 22 districts of the country. As I talk to you, dengue flares. Previously, it used to be seasonal, but now it's every year. Even today, we had, I think, 3 or 4 patients die of dengue fever. And these are, again, very formal figures. Informal figures may be much more. Several years ago, we did a small trial, and that was on the NIH's vaccine. We found that it was very much immunogenic. We have decided to have a phase 3 trial among 3,000 participants in Dhaka city. We very much need this tetravalent dengue vaccine because of the huge burden of both morbidity as well as mortality in the country. And I must tell you that one of the local pharmaceutical industries has been given the license by NIH to manufacture this vaccine. And again, for this, ICDDRB had to play a very important role. Talking about infections, and you can see on this slide, these are the stool characteristics of children suffering from invasive diarrhea, namely shigellosis. Shigellosis still, it kills children, and also enterotoxigenic E. coli. Right now, we are in the middle of testing a combined vaccine. If successful, you take just one vaccine, and this is going to protect you against both shigellosis as well as ETEC, which is a very important cause of travelers' diarrhea. Very recently, we have decided to take up cancer diagnostics because this is very, very important. Among the main causes of cancer, we have this breast, cervical cancer, esophagus, gallbladder, lip, and oral cavity. And then you can see what happens in the country. Many of the patients, they have to go abroad. They have to go abroad first for diagnosis. diagnostic capabilities in the country are still very rudimentary. And the country had to spend a huge amount of foreign exchange supporting the travel and treatment of such patients. Based on the requests and recommendations of oncologists in Bangladesh, ICDDRB, through its Genome Center, is now offering a number of NGS panels. Last year, we purchased the next-gen 2000 sequencer, and we are using it for all these panels, ranging from BRCA Pro to HRR, and then you can also see the classic and the myeloid panels. And I'm sure that this is going to go a long way in helping patients suffering from different forms of cancer in the country. As I said at the outset, we are working quite a lot taking care of the Rohingya population, 1.3 million. They are concentrated in the district of Cox's Bazar near Teknaf. At Teknaf, we operate a small hospital. This was primarily meant to take care of severe COVID-19 cases. Now that we don't have COVID-19, at least in the severe form, we have decided to refurbish it as a hospital for respiratory diseases, which is pretty common. Close to Teknaf, we have established ICDDRB Climate Change and Health Impact Hub. This is what you see if you travel to Chakoria. This is very remote in the deep south, and we have a very nice center, which also a few living quarters. And very recently, we have embarked on a very important study. This is on the microbial mediation of climate change impact on human health at this Sentinel site, established a small laboratory, and this is what we are doing with the support of Wellcome Trust. ICDDRB has been very active, and I think this was started by Dr. KMS Aziz many years ago through the training unit that we have. We sent teams of doctors, nurses, microbiologists, infection control professionals to different parts of the world, primarily at the request of the national governments and also at the request of WHO as well as UNICEF. And you can see as ranging as disparate as Haiti to North Korea even. And this is just to tell you that we are visited, and this is Mr. Ban Ki-moon, the former United Nations Secretary General. And for all the work that ICDDRB does and did in the past, inspired by people like Dr. Rita Colwell, ICDDRB has been recognized both within the country and outside. And this is the Bangladesh Independence Day Award given to ICDDRB in 2005. We received the Hilton Humanitarian Prize. Many consider this to be the Nobel equivalent in terms of humanitarian activities. This was in 2017. I'm sure that many of you know our senior colleague, Dr. Firdausi Qadri, who received the Independence Award in 2023 for her lifelong work on vaccines. I must tell you, and I will conclude with that, about the clinical service. ICDDRB does a lot of research, publishing more than 500 original articles every year. But it does a lot of training, health professionals, not just in Bangladesh, from other parts of the world. But what we do is very remarkable. We take care of more than 300,000 patients every year, 200,000 from the Dhaka hospital alone. And all this is provided free of cost. And with this, I want to thank you for again giving me the invitation to talk to you. Thank you very much.
Thank you very much, Dr. Ahmed, for your highly insightful and inspiring plenary lecture.